Welcome back, YouTubers, to my channel of an everyday life of an Aspie. If you're new, I'm Aspie. I'm all about creating mental health and awareness and sharing my life stories with autism and mental health, along with advocating and educating you all, along with fun and games and tips and advice. So if you haven't seen any of these, feel free to smash the subscribe button on the bottom right hand corner, because you never know when I'll be up to date with some of these topics and more. So you may be wondering right now, basically, what's the next topic in the autism series that I'm trying to bring out to you more, as well as mental health. So as it reads, obviously, this is part 1 of autism and eating disorders. So just a brief definition or meaning of an understatement of what autism spectrum disorder is about, since now, you know, Asperger's syndrome, with what I've been diagnosed, obviously, is now classified under the umbrella of autism, hearsay, and many other jurisdiction of also autism spectrum disorders. So obviously, as I mentioned so many times before, what it is, I'll link it in the iBar as well as in the description below, that it's a neurobiological condition that is defined by many limitations in communication and social interaction with our peers. However, the secondary or ancillary aspects of the condition typically receives the most interest in research and practice, including atypical sensory processing and stimulus over-selectivity, or in this case, you know, just hypersensitivity versus the hyposensitivity. Autism studies have maintained a strong pediatric focus, however, despite the fact that most people on the spectrum are adults, because obviously, as I'm sharing with you all, most of the time, you know, most of the stuff that are shared are based on children with autism, and I'm hoping that in some way I can advocate for adults, from transitioning from you know, when they're in their preschool to maybe say teens to adult life, because obviously we do struggle as well, so to speak. And as a heads up also, every autistic you meet will be different with their different needs, be it on what end they are at over their life and developmental stages, hearsay as well. And in saying this also, basically, you got to bear in mind that it's a really long road for many of us. Anyway, as I said before, basically, consequently, a consensus is now emerging that for too long, adult cohort has now been neglected, as I've said, and this is why I'm here today, preventing a complete understanding of the health-related patterns, including eating disorders during the eating pathologies for children on the autism spectrum have been relatively well studied, with a highly cited figure of 90% of prevalence for this cohort. And bear in mind, some of the statistics I'm bringing out to you will be US related, which I humbly apologise. I was trying to look for some of New Zealand statistics, but some of the studies that are here are brand new, so many of it'll be a bit limited here in New Zealand. So I'm just going to bring it out from United States reports, findings, just to give you a clear understanding anyhow. A new study among adults with autism has reported a range of eating disorders that has spanned from 6% to at least 17% of the population. However, our understanding is greatly affected by the way the diagnostic criteria has been established under this new manual of the DSM-5. However, the language states that if an eating disorder is subsidiary to a mental condition, which is obviously an example here on what I'm expressing today, autism, then a secondary diagnosis is not warranted except in certain circumstances. For example, the presence of PICA, where outcomes are sufficiently then are severe. The consequences of this are profound, as it prevents autism researchers from determining the true rate of prevalence. This in turn inhibits discussion on how eating disorders should be conceptualized, assessed, diagnosed, or treated for this and other cohorts with disabilities. Consequently, autism studies remain in the early stages of making sense of these type behaviors. So this video will hopefully overview the looks at the manifestation of this disordered eating patterns from a broad view, and may argue that 4 expansive types of the disorders of eating that can be defined, which I've also shared a bit about the different types of eating disorders, which I'll link in the icon above me as well as down below me to understand more. This will then be discussed in terms of manifestations, clinical and current treatment options. So the 4 categories of disordered eating on the autism spectrum to look out for. Behavioral rigidity is number 1. Behavioral rigidity is a characteristic of many psychopathologies, including autism, and the difficulty in transitioning between activities, environments, or even internal aspects of the same task. Behaviour rigidity is often reflective of deficits in self-regulation. The first category of disordered eating reference is this type of behaviour in the context of food and consumption. Behaviours on the autism spectrum falling into this category includes food cravings, food refusals, and particularly a limited diet. And again, I mentioned before I continue, is autistic children are fussy eaters, which I'll link in the iCard as well as in the description below me as well, so you can get a better understanding. In this last group, both the narrow focus on specific foods as well as over-reliance on specific food classes, e.g. refined carbohydrates, can predominate, because these varied behaviours are not driven by concerns about either body shape or weight. They are positioned as analogous to avoidant restrictive food intake disorder, which again I've done also a video on this, which I'll link in the iCard above me and in the description below to understand more. Restricted eating on the spectrum, however, has been mostly thoroughly been studied in children and has been noted as one of the most predominant eating related patterns during this period of the life cycle in our everyday life. Treatment for food rigidity relies primarily on behavioural techniques, especially escape extinction, where food is continued presented until acceptance occurs. However, the results of research studies have shown that increasing overall food intake has been more successful in interventions than as a means of increasing actual dietary variety. Next one on the list is your sensory abnormalities, which is number 2 of the second category for this disordered eating and autism. This will include things that will affect the hearing, vision, touch and smell, for all those 5 classic senses. For all of these systems, atypical sensory functioning is likely to contribute significantly to eating pathologies, though there are still only limited research on this. As with most autism-related studies, children have been primarily focused where oral preferences and motor difficulties have been noted, along with more generalized sensory abnormalities. One small study accessed higher functioning adults for the ability to discriminate among taste samples. Although the sample population was found to be less accurate in identifying bitter, sweet, sour taste with the healthy controls, they were more comparable to a control group in the identification of salty foods. A review of olfaction for individuals with ASD, however, found possible involvement of impairment of sensory systems, suggesting more study is merited. Early tactile sensitivities have also been proposed as a contributor to the specific food preferences. From a qualitative perspective, however, on this topic, they can be explored in more depth by reading the autobiographies and memoirs of high-functioning individuals with autism. For example, Stephen Shaw, now a professor and autism advocate, remembered growing up in the following way. Brown or black food wouldn't be eaten, as he insisted that they were poisonous. Canned asparagus were intolerable due to its slimy texture, and he doesn't obviously eat cherry tomatoes or tomatoes for a year after a cherry tomato had burst into his mouth while eating it. The sensory stimulation of having that small piece of fruit exploded in his mouth was too much to bear for him, and wasn't going to take any chances for that happening again. Carrots in a green salad and celery in tuna fish salad are still intolerable for him because the contrast in texture between carrots or celery and salad or tuna fish is too great for him. However, he enjoys eating celery and baby carrots by themselves. Often as a child, or at least now, he would eat things serially, finishing one item on the plate before going on to the next. This ability to articulate inferior rules has contributed to a better understanding of how food, including the size of the bolus, texture, flavour, colour and shape, can affect the eating patterns for this population. The third category is disordered, and the disordered eating on the autism spectrum incorporates a disparate group of behaviours that is, because of the significant health-related risk, requires substantial resources and support staff to manage. This group includes pica, rumination, and disruptive mealtime behaviours. Despite the severity, there are no clinical guidelines for this assessment or treatment. Pica, or eating non-nutritive substances, is manifested in the general public as discriminative connotative behaviours, typically involving a single class substance. For example, pregnant women eating clay. On the autism spectrum, however, this behaviour is usually manifested in a non-discriminant consumption patterns that likely favour opportunity. Cigarette pica is reported as the most commonly ingested item for this population. Or should I say, despite the fact that rates of nicotine, caffeine and drug abuse are currently very low. The highest rates of picker behavior on the autism spectrum, from 26 to 65% here, has been documented in institutionalized settings. Rates are significantly reduced in community-based residences where there's greater emphasis on social stimulation. Treatment for patients on the autism spectrum typically addresses picker as either a challenging behavior or a psychopathology. Challenging behaviors are considered culturally abnormal actions that can either put the individual or those around them at risk, or that are so disrupted as to limit access to the community and the ability to affect quality of life, limit independence, and create a social isolation. Challenging behaviours are among the most studied and one of the most socially unacceptable aspects of ASD. However, learning-based approaches are common for treatment of this challenging behaviour, and this will include applied behaviour analysis, behaviour therapy, social skills training, reinforcement models, and token economies. Here is a psychopathology typically relies on psychological explanations of autism. Though conditions such as anxiety, depression, or even psychosis, however, are difficult to differentially diagnose in a population that's 40% nonverbal. Psychiatric symptoms are highly prevalent, with rates for comorbidities ranging from 36% to 81%. Pharmacologic approaches for the treatment of PK have included the use of selected serotonin reuptake inhibitors, often fluoxetine, based on anti-anxiety and anti-obsessive properties. Both antipsychotics and atypical antipsychotics have also been utilised in treatment with varied effectiveness. Medications are likely the most common treatment modality for all forms of controlled behaviours, or what I've mentioned just now. Basically, based on this, is obviously particularly in adults. They have also been linked to the etiology of picker. Research as to underlying causes of picker have been found that psychotropics and anticonvulsants are significantly associated for individuals with ID who displays of picker. Neuroleptic medication is also believed to have a link with picker, possibly due to diminished post-synthetic dopamine receptor changes, which may worsen the behaviour. Whatever the perspective, however, here, basically, the predominant treatment for picker behaviour outside of research contexts is simply picker proofing the patient's environment. In treatment settings, this usually involves the use of additional staff to protect an individual by sweeping a room for possible picker items and by limiting the opportunities to engage in picker behaviour within the larger community. As the next one is also documented on the spectrum, though its prevalence isn't completely understood due to the difficulty in clinically identifying this condition in non-verbal populations. Rates of rumination for individuals with autism and ID are estimated in the range of 6% to 10%. Along with the immediate risk of aspiration, rumination contributes significantly to increased mortality rates, as well as long-term concerns about dehydration, malnutrition, and gastrointestinal bleeding because of the silent nature of this condition and the significant outcomes that comes with it. Identification of rumination warrants a full clinical workup. Treatment options for rumination on the spectrum have focused on supplemental feedings to break regurgitation cycle, use of preferred stimuli, and emphasis on overall increased or alternative stimulation. Last group of disordered eating has noted on the autism spectrum involves a range of rapid eating behaviours that approximate binge eating disorder, or BED for short. Binge eating has been documented in institutionalized adults with ID at rates ranging from 3% to at least 42% of the population of adults in the community-based residences. Reduced rates ranging from 1% to 19% has been noted. There's relatively strong anecdotal evidence and some research to demonstrate that rapid consumption patterns are highly prevalent on the autism spectrum and more generally established among individuals with developmental and intellectual disability disorders. Traditionally, the predominant risk of rapid eating were believed to be related to aspiration, choking, and weight gain. An override of the saturation markers. For those with autism, it's also likely to contribute to both ingestion and ongoing social isolation. New research on this topic has documented a relationship between a high body fat ratio and rapid eating and hyposensitized, and a relationship due to insulin resistance. In designing treatment modalities, however, for all populations that are addressed rapid consumption, the challenges will lie in overcoming the fact that the food of choice in itself reinforcing. Thus, the faster the individual eats, the faster they consume, thereby shaping rapid consumption. Typical strategies for treatment on the spectrum often involves placing support staff, so therefore they can actively coach a reduction in the speed of bites. Newer, more innovative strategies utilizing technology have incorporated the use of a vibrating pager to cue consumption at fixed intervals. This approach has been found to decrease the rate of eating in teenagers on the spectrum and in several cases studies of adolescents, but it's not currently in widespread use. Rapid eating as manifested in binge eating disorder was first included in the DSM-5 manual, however, and now is the most common eating disorders in the United States alone. From the perspective of a formal diagnosis, binge eating disorder is considered to be idiopathic and is identified by an absence of compensatory behaviours such as co-occurring AN or BM. The formal BED diagnostic criteria demonstrated the difficulties of applying this DSM-5 language to individuals with autism, however, and even when the behaviour is highly prevalent. Due to communication deficits and alexithymia, applicability of stipulated criteria for binge eating disorders would necessitate translating subjective symptoms to objective signs. By adjusting these criteria, it is possible to create applicable standards that capture behaviours manifested in those with autism. The only exception to this is the identification of disgust, depression or guilt, which would be impossible for any individuals on the spectrum to identify. Likewise, embarrassment for many individuals would be impossible to label, but stealing food is a commonly noted behaviour and can be other means to come in this criteria. Though cognitive behaviour therapy has found widespread acceptance for treatment of the binge eating disorders within the general public, it's only has been used with the most highly functional cohort on the autism spectrum. Even here, those subjects were found to have difficulty in grasping cognitive restructuring and organising to various sections. Doubts and concerns were also raised regarding maintenance of behaviour changes and generalising ability. This broad view of disordered eating on the autism spectrum makes it clear that these behaviours are widely manifested and requires significant resources in terms of staff time and attention. Despite this, clinical understanding in terms of assessment and treatment, however, does remain limited. Disordered eating on the autism spectrum is clearly a neurozone for eating disorders professionals who have the skills and knowledge to make a tremendous contribution to this at-risk population, and hopefully in this can keep it down. So this quickly ends a quick video of me doing about autism and eating disorders part 1. Hope you like this. Smash the like. Comment below if you've got an eating disorder and you're on the autism spectrum, disorder or not, and how do you go about with your eating disorder. Is there any way that you control these eating disorders? Because I've heard many stories about this, but feel free to open up that for discussion. And all for the do, guys, thanks for watching. Do love it, do. And don't forget also, as I said in my last video, that at the moment, as of the 28th to the 5th of March, if you go to my merch store, if you're interested in some of the new merch stuff I've been creating right now, it's up there. You get 15% off. You get a discount code, which is obviously will be listed in the description as well as on the screen where to find all this. And also saying this, I'm also got a Patreon place to raise some funds for myself and whatnot, and hopefully in saying this we can do something together in Autism Awareness Month, as I shared before in my last video. So no further ado, guys, thanks for watching, and I'll see you again soon.